to this meeting on telepedes. This is the third meeting we are having after we started this program. And today is an interesting. It is not a regular presentation, and we have decided to have a panel discussion on a topic which is extremely interesting and relevant to pediatric practice, and that is kidney stones in children. So we have esteemed faculty here and who will be panelists for the evening. I will just start. Hope the screen is visible. So the first panelist is Dr. Vinay Agrawal. Sir is an Associate Director in Pediatric Nephrology at Max and Pediatrics at Max Smart Super Specialty Hospital, Saket. Sir is a well-known person as far as pediatric nephrology is concerned, and he has experience of over 42 plus years in pediatric nephrology per se. And we welcome you, Vinay sir, for this program.
Thank you.
Second is Dr. Yajvinder Pratap Singh Rana. Sir is a director in neurology and uro-oncology at BLK Max Center for Renal Sciences and Kidney Transplant at BLK Max Super Specialty Hospital. And sir has been working as a director he's currently working as director and has a vast experience in renal stones and pediatric ureteric problems in children. Welcome, sir.
Thank you, Dr. Vivin.
Lastly, we have Dr. Anjana Mishra. She is working as a consultant in clinical genetics at BLK Max Super Specialty Hospital. She has over 17 years experience in OBG and over 6 years experience in medical genetics and various publications under her name. Welcome, Dr. Anjana.
Thank you.
So to moderate this very interesting session on renal stones in children, we have none other than Dr. Swati Bharadwaj. She's currently working as a senior consultant pediatric nephrology at BLK Max Super Specialty Hospital, and she has done her MD Pediatrics from PGI Chandigarh and fellow of ISPN, and also trained pediatric nephrology from AIMS New Delhi. There won't be any person better than her to moderate this session and carry on this session in the most useful way as possible. I hand over to Dr. Swati, and without any wasting time, let's start on with the session. To you, Dr. Swati.
Yeah, thank you, Dr. Vibin, for kind introduction, and very good afternoon to everyone. So today we are going to discuss a rather topic which is fairly commonly seen in adults, but not so commonly seen and obviously not commonly discussed in children. So through this panel discussion, we would be discussing the clinical approach to management and evaluation of children with kidney stones. So kidney stones are common in adults, and its prevalence varies according to the geographical location, being more common in Europe and USA as compared to Asia. And last 2 decades have seen a rise in incidence in children as well, although we do not have any data for Indian subcontinent. And this rise is particularly seen in adolescent females, and the incidence in young children has remained constant. So, Dr. Vinay, could you share with us your experience about kidney stone disease in children, and what could be the reasons for this rise in incidence in children?
You see, the kidney stones is a disease of industrialized world. As a young doctor, we used to rarely see kidney stones in children. It was usually the bladder stones, which was related to malnutrition. But as our country is also getting more industrialized and the dietary habits of children are almost as in the westernized world. Kidney disease in children is also becoming common. And the main sort of factors are really the lifestyle and the diet. The diet which has got more salt, less of potassium, inadequate taking of calcium, less of water intake, lots of antibiotics are being taken. That alters the bacterial flora of the intestine, and that leads to renal stones in different ways, which we will discuss later.
Okay. So Dr. Rana, could you share with us your clinical experience? Have you also seen a rise in surgical interventions required for kidney stones in children?
Yes, really, we have over the period of last decade, what we are observing is that the kids with the kidney stones, they are coming more frequently, and the bigger size of stones. Earlier, they were used to have the small concretions. The medical expulsive therapy were very successful. Nowadays, big stones of 10 or 15, 20 of stone, kidney and ureter, we are seeing in more numbers. So I want to add one thing here because of the rising obesity in the kids. The more the mobile sports, not they are not more into the physical sports, less activity, and all that sort of lifestyle. What we talk in adults, that is all applicable for kids as well.
Very rightly said, sir. Kidney stones are more a disease of lifestyle. And so what is the composition of pediatric kidney stones? Is it similar to or different from adults? And has it also changed over the last few decades?
It's
Yes,
almost similar to adults as well. So most common stone composition, what we see is calcium oxalate, then the calcium phosphate, and the struvite stones. Urate are also quite common, and occasionally the cystine stones.
Dr. Vinay, would you like to comment about the composition of stones?
Yeah, in very young children, because their diet is mainly milk-based, so you will see more calcium phosphate stones. But the calcium oxalate stones remains the main type of stones even in children. And of course, then we have rare genetic disorders like cystinuria and hyperuricemia. We will have some degree of number of children with cystine stones and the uric acid stones. The incidence of struvite stones, which are related with urinary tract infection, have decreased. Mainly because UTI is very early diagnosed and very adequately treated. So we are seeing less of these magnesium ammonium phosphate stones, which are usually as a result of urinary tract infection. So the composition also varies from the age, as I described to you.
So, sir, could you tell us what are the risk factors for pediatric kidney stone disease?
So as we have already talked about, that apart from the dietary and the lifestyle issues, the children have a few different things from adults, which are much more common. Certainly, there are some metabolic disorders which are seen in children. There are two which I would say are important. One is hypercalciuria, meaning they excrete much more calcium in the urine, and hypocitraturia, the decreased secretions of citrate in the urine. And then there are genetic disorders. They are uncommon, not that uncommon. I would either say that something like 1 in 100,000. And one of the nastiest illness is primary hyperoxaluria, where the enzyme in the liver is deficient, oxalate is not broken down, and hence the oxalates gets deposited. So these are metabolic and genetic, And as I said, urine infection is common in children. So some of the screw-white stones will be seen, particularly, in contrast, if there is an obstructive uropathy, the structural abnormality is also more commonly seen in children. So
Okay,
these are the risk factors.
Dr. Rana, could you tell us a bit more about the screw-white stones? As a surgeon, you might be dealing with these more frequently.
Yes, the screw-white stone, basically whenever there is any obstruction in the urine passage. So we see if there is a puja obstruction or any ureteric obstruction in the mega ureter as well, in the ectopic kidneys, in the horseshoe kidneys. So these kids, they have recurrent UTI. Later on, these stones start forming and growing faster rate. So yes, that's it. So all these stones, they are multiple stones, big stones, and the complicated stones.
Probably the most complicated ones because they are very difficult to get rid of, and recurrence rate is also high in these. So as for any disease, the evaluation begins with a detailed history that should include medical history as well as history regarding the diet, fluid intake, medication intake, etc. And we commonly see a positive family history in children with kidney stones. So I would like to ask Dr. Ranjana, what is the relevance of positive family history in pediatric kidney stone disease?
So thank you, Dr. Swati, for this very important question. Family history has been shown to contribute to 30% of all pediatric kidney stone disease. And there are pointers towards common environmental, dietary risk factors and a possible underlying genetic etiology as well. So we have, twin studies which are undertaken to determine the heritability factor. How much genetics can contribute to the disease. So it has been seen that there is a heritability of up to 50% in cases of pediatric nephrolithiasis. And various studies have shown that monogenic cause, that is single gene causing nephrolithiasis or nephrocalcinosis, they account for up to 30% of these cases. So it becomes very important to identify these conditions, these genetic conditions, for the correct diagnosis, treatment, and surveillance.
So could you please tell us some red flag signs that any child who comes with kidney stone disease, the signs we should look for which may point to a genetic etiology, and when we should consider genetic testing?
Working up for the genetic etiology does not form the first line of management. Although one should always, whenever one sees a patient with nephrolithiasis, one should look for these red flag signs, which have been very nicely elaborated in this table. So what are these? They are, whenever you see an early onset nephrolithiasis, so as early as, there are cases reported in the infant age group as well. When there is a family history of kidney stones, consanguineous parents, because here there is a risk of autosomal recessively inherited disorders. Then whenever you find highly active stone disease like bilateral stones, multiple stones, or frequent or recurrent stones, then if there is associated nephrocalcinosis, if there is evidence of renal hyperechogenicity, renal failure, tubular dysfunction, and related manifestations like growth deficit, polyuria, and bone disorders. And once you come across extrarenal manifestations, which could be syndromic, underlying syndromic disorder you could be dealing with, like sensorineural hearing defects, ocular abnormalities, which you see in cystine stones, neurological disorders, dysmorphism, developmental delay. So these are pointers towards an underlying syndromic etiology. Then sometimes a particular stone composition and crystalluria should also alert you, like monohydrate calcium oxalate stone in primary hyperoxaluria, cystine stones. So these are some pointers towards thinking of an underlying genetic etiology and doing those genetic tests as a second line of investigation.
So talking about crystalluria, some crystals like calcium oxalate and uric acid may also be seen in the urine of normal individuals where a urine microscopy is done for other reasons. But if we see typical crystals like 2,8-dihydroxyadenine, typical Maltese cross pattern, or cystine crystals, then this may be pointer towards the diagnosis because they are not seen in normal individuals. So in this way, identification of particular crystals also helps in narrowing down the diagnosis. So Dr. Ranjana, could you further tell us what are the common monogenic causes of pediatric kidney stone disease and how frequent they are?
So, like we had discussed, the monogenic causes, they account for approximately 10% of all kidney stone disease in the pediatric age group, whereas this contributes to only 2% of the adult population. So herein lies the importance of working up for the genetic etiology for in the pediatric kidney stone disease children. So what are the common monogenic disorder which we see, which account for these nephrolithiasis? They are the autosomal dominant idiopathic hypercalciuria, renal tubular acidosis, the various types, primary hyperoxaluria 1, 2, and 3, Den disease, cystinuria. So there are, to name a few, and currently there are 41, about 41 genes which are known to cause these monogenic nephrolithiasis. However, more are in pipeline. So as you know, as the literature expands, as discoveries are being done, so we will, it is no surprise they will encounter more of these genes. And if we talk about the worldwide scenario, so it has been this study on around 268 pediatric KSD patients, which was done in Germany, and they have seen that around 20% of the pediatric patients were accounted for by an underlying monogenic cause, whereas this composition in the contribution in the adult was only about 10 to 11%. In India, recently in AIMS, in 2022 itself, a study was undertaken in 54 patients in the age group of 1 to 18 years. The mean age was about 9 years in this cohort. Familial cases were 33% and 25% were recurrent cases. The most common stone was hypercalciuria, and hyperoxaluria was the second most common. Here again, as compared to the worldwide literature, a confirmed monogenic cause was found in about 11%. So if we talk about now, what will be the implications of getting a genetic testing? So before I enumerate some of these examples, whenever we send out genetic testing, it is very important to start with the pre-test counseling. That goes hand in hand. So no test should be ordered randomly. A pre-test genetic counseling followed by a post-test genetic counseling is mandatory. So now this was a study in about 160 patients where the clinical diagnosis was something which changed after the genetic diagnosis was made. So just to enumerate a few examples, like there was the number one patient which I've just taken is a patient who was initially suspected to have incomplete distal RTA. After the genetic diagnosis was done, this was confirmed to be a distal RTA type 2 with sensory neural hearing loss. So this patient was put under hearing screen and monitoring for hyperkalemia. Similarly, cystinuria was suspected and confirmed with genetic diagnosis. But then definitive treatment, after you have done the genetic diagnosis, you have done a definitive diagnosis. It's the final diagnosis. So this patient could be put on tiopronin, which is the drug of choice, and potassium citrate for management. So there's something, now this third case, the primary hyperoxaluria. Here I just wanted to mention that many a times that happens that without working up the patient for the genetic etiology, these children, these adolescents may undergo kidney transplant as well, and which many times happens in primary hyperoxaluria. So an allograft transplant, renal allograft, may again manifest with the nephrocalcinosis, oxalate nephropathy. So that is because one has missed an underlying primary hyperoxaluria. So again, there was another case of primary distal RTA, which was the initial diagnosis. And after the genetic workup, this was found to be distal RTA type 4 with a hemolytic anemia component also. Again, this child was put on hereditary monitoring for the hereditary spherocytosis, monitoring for osteomalacia, hypokalemia, and periodic paralysis. So similarly, for a patient with vitamin D resistant rickets type 2A, who was initially thought to be hypophosphatemia, after the genetic confirmation, child was put on high dose calcitriol and calcium supplements. So the message here is that genetic testing, doing the genetic testing shortens the diagnostic odyssey. It has the potential for personalization of treatment plans and monitoring as per the natural history of the disease. And of course, there is scope of counseling for asymptomatic family members as well.
Thank you, Dr. Anjana. So we should carefully select our patients whom we need to order genetic testing.
Right.
And let us now look at what are the common clinical presentation of kidney stones in children and how do we go about evaluating these children. Dr. Vinay, please.
So the commonest presentation, it is very variable. Sometimes you just do an ultrasound, and the ultrasonologists do an ultrasound for non-specific things, and they may find a stone sitting in the kidneys. So that is one part of the presentation. But commonly, the children have abdominal pain. They will complain of loin pain and classically sort of radiating towards genitalia. That is the typical renal colic pain or the ureteric colic pain. And sometimes the presentation is just gross hematuria, which may or may not be without abdominal pain. And then there will be symptoms which may suggest the child may have urinary tract infection, going to the toilet frequently and increased frequency, and maybe a bedwetting as well. And vomiting or nausea may be associated mainly because of the severe abdominal pain that may be there. So the presentation is pretty variable, but I would say abdominal pain and hematuria are perhaps the two commonest ones.
And how do we evaluate these children?
As far as the evaluation is concerned, in the beginning, you just need to do two things. Just do a urine routine microscopy. Don't need to do a culture in all the cases unless you are suspecting there is a urinary tract infection. And another is an ultrasound. Ultrasound is a very sensitive method of knowing whether this pain or hematuria is because of the stone or not. These days we have got a high resolution ultrasound. They will hardly miss any renal stones, although they can miss a ureteric stone. But then, ureteric stone, you may not be able to see the stone itself, but there will be some hydronephrosis. So presence of hydronephrosis or visualization of stone on the ultrasound gives a good enough indicator, along with the urine routine microscopy, which will show some degree of hematuria, microscopic or macroscopic. That will tell that you're dealing with the abdominal pain is due to presence of renal stones. So that is basically these tests are more than enough for the initial evaluation. And what needs to be further done, that depends on lots of factors, as we have already discussed. What are the red flags? And the most important red flag, I would say, is a younger child. As if a child less than 5 years of age gets a stone, that child has to be definitely evaluated.
Yeah, rightly said, sir. So most of the time, even ultrasound examination would suffice, and it is without radiation, and follow-up test can also be done. Dr. Rana, could you please tell us what is the role of more complex investigations like CT or MR urography in patients with kidney stones?
So I'll actually totally agree with Dr. Vinay. For the initial assessment, ultrasound is good enough. But for planning a proper surgical or the therapeutic, whatever way we are going to treat the patient, we need at least a CT scan. So small concretions in the kidney, we can just follow with the ultrasound. If there is hydronephrosis and the stone size is not visible on ultrasound, this is the indication for getting a CT scan. Or patient having persistent pain, sometimes there is hematuria also. So the CT is very, very important and helpful whenever we are going to plan the surgical treatment. So usually we go ahead with the non-contrast CT as well, CT only. And IVP nowadays is obsolete. We are not doing any more IVPs. If required, the contrast study like CT urography is helpful. So MR urography, we don't go for MR urography in the initial cases because the stone, they are missed on the MR. But when there is high creatinine and some other congenital anomalies like VUR or something, and we can't give the contrast, then only the MR urography is indicated.
And
so something about yes, dual energy CT scan, and with these CT you can get some information about the composition of the stone also. So we did one study also for that. So this was quite appropriate in majority of the cases. So that you can, without getting the stone analysis, the chemical composition, the radiological assessment is also helpful for monitoring and advising them the medical management.
So a 11-year-old boy presents to the emergency with severe pain in the left lumbar region, radiating to the groin area with vomiting and hematuria, and an ultrasound confirms the presence of a 5 millimeter stone in the lower 1/3 of the ureter. So how do we go about managing this patient? Dr.
So, yeah, so this child the pain has to be relieved. That is the first and the foremost thing. The pain due to stones is of moderate to severe category. And we should be aware of what sort of analgesia is usually useful and what particular setting is comfortable of giving the analgesia. So the two commonest which are used are non-steroidal anti-inflammatory drugs, which is diclofenac and ketorolac. Now, ketorolac became much more popular mainly because the soluble ketorolac was available earlier than the diclofenac. Now, in our country, we have got a soluble diclofenac as well, so which can be given intravenously. And if the pain doesn't get relieved, and there are certain countries which use opiates as the #1 drug, because they consider that the pain is severe and the pain has to be relieved. So they use things like pethidine and dihydromorphone, which are non-addictive. I specifically have missed, antispasmodic drugs. Now, somehow in India, antispasmodic drugs are very popular. The trade names, Drotin and Buscopan. And I'm personally not in much favor, although I do know that there are some people who will give antispasmodic and diclofenac or things like that together. At least as far as I'm aware of it, it is not approved drug. Antispasmodic drugs in renal stones are not an approved FDA drug. But as I said, surely it depends upon your experience and the local facilities available. You may like to use one drug or the other. So relieving the pain is important. And if the child is vomiting, then you have to give some antiemetics. And because you're going to use non-steroidal anti-inflammatory maybe afterwards as well. So some proton pump inhibitors have to be used. And in this particular case, it is already in the lower 1/3 of the ureter, and it is 5 millimeter. Most likely this stone will come out on its own. So what we talk about is a medical expulsive therapy, which mainly means giving adequate amount of oral fluids. There is no need to admit this child for giving an intravenous fluid, that we used to do long time ago. But if a child is able to take oral fluids and have a good urine output, and that depends upon the age and the weight, so that is usually good enough. Certainly, alpha-adrenergic blockers are helpful because the ureters and the bladder neck wall are very rich in alpha-adrenergic receptors, and they do help to relax the lower part of the ureter and expulsion of the stone. Same thing can be achieved by using calcium channel blockers as well. So this is the commonest, which we have much more experience, is Temlucin, which we give it to the children.
So what
The
about
next question?
Alkali therapy during acute management?
Yeah, you know, whether you should be using alkaline therapy during acute phase or not, that is a little bit debatable, I would say. But we all tend to give it. We want the urine, without knowing, to be in almost a neutral pH. You know, we don't want the urine to be acidic because we presume most of these stones are calcium oxalate. So the crystallization of the calcium and the oxalate depends upon the urine pH. So we do use these alkalining agent. And you may notice, you know, these days, some of the companies are adding pyridoxine as well in these alkalining agent. You know, the pyridoxine is a cofactor which helps in metabolizing the oxalate in the liver. How much it is useful, I'm not sure, but certainly there are some cases of primary hyperoxaluria which are pyridoxine responsive. But should we be using additional urelyzer plus B6 in all the cases? I've got doubts about that, but certainly it doesn't do harm. So, you know, people do tend to use. In majority of cases with urine stone, we want the urine to be near neutral, you know, somewhere around 6.3 to 6.5. Only exceptions are, I would say, struvite stones, where we don't want the urine to be near to the alkaline pH.
So, sir, how to follow up this patient and any follow-up imaging required?
So, if you have identified that a child has a stone or even have a hydronephrosis, you have to make sure, although the child may become asymptomatic, that this stone has been expunged. And, you know, if the urine, there is obstruction for long period of time, that can lead to infection and even pyonephrosis. So normally, you know, we do an ultrasound after 6 weeks to make sure that the kidneys have get back to the normal. And if there is a small stone somewhere sitting in the kidney, perhaps we don't do anything. But if the ureter, the stone is still stuck up in the lower part of the ureter, then, or there is a persistent or even intermittent gross hematuria, then we have to think of surgical intervention.
So, regarding evaluation of risk factors, so, sir, you could please enlighten us about how to evaluate for metabolic risk factors in these children.
Yeah. As he said, you know, as a pediatrician, younger the child, more aggressive we are for doing investigations in children to know what is the cause. It may be a small stone, it may be a first time the child may have the stone, because the genetic disease itself can have varied presentation. We have already said we are going to take the medical history, family history, and if possible, if we can come to know what type of stone it is, that's very helpful in vivo. Or even if the child has expelled the stone, we always tell parents to keep that stone. So, you know, that analysis of the stone can be done. And the basic works like kidney function, and make sure there is no marked acidosis, which is usually seen in renal tubular acidosis. And the urine analysis, if you're lucky, you will see some form of the crystal, which will indicate, the child may have some particular genetic disorder. But just to highlight, calcium oxalate in itself, which is common in all patients, you can see them, and they are not to be normally to be sort of they don't deserve the further evaluation. And the first thing, after the child has recovered after 4 to 6 weeks, is the collection of the urine sample, which is a tiresome sort of thing, troublesome. Although we can do we take as a creatinine as a marker, so we can do calcium creatinine, we can do uric acid creatinine, we can do cysteine creatinine ratio and the citrate creatinine ratio. But the real gold standard is really 24-hour urine. And an ideal lab will like to have 2 samples of 24-hour urines, one in an acidic bottle and other one in the plain bottle. And in a small child, say, I'm talking of, just think of if you got a child who is 1.5, 2 and has a stone and you want to evaluate him, sometimes you have to put a catheter really to collect the urine to have an accurate estimation of these metabolic products. And once you have find out some metabolic disorder, or if there is a suspicion on the medical history or in the initial investigation, and then you think of doing genetic mutation studies.
So once we have heard about medical management, Dr. Rana, could you please brief us about the indications and the methods of surgical intervention? So we need to wind up in next 5 to 7 minutes.
No problem. I'll quickly, whenever medical expulsion guidelines, the case which
So we are losing your voice, and Dr. Rana, are you there? Maybe there is a network issue, but the presence of infection. Okay. Yes, sir. Yeah.
Presence of infection, symptomatic stones, all these solitary kidney. These are the indications when we have to intervene surgically or do something for removing the stones. Like stones less than 3 mm kidneys, just the conservative management. Stones up to 10 mm in the ureter or in the pelvis. The first is the ESWL. ESWL is sound waves. They are quite safe, as in adults in pediatric age group also. Quite safe is the lithotripsy. When the stones which are bigger than the 10 mm, 10 to 15 mm kind of stones, then ureteroscopic removal of the stones. Swati, am I audible?
Yes. Yes, sir. Better. Your voice is better than.
Okay. Right. So the ureteroscopic removal of the stones. Then the third option is mini PERC. So mini PCNL nowadays with the miniaturized endoscopes, with the small scopes up to the 6 or 8 French size diameter, we can remove the do the PCNL and remove the stone. This is a small video wherein we are going through the urethra and entering into the bladder and the ureter. So we can proceed to next video where the stone fragments are being fragmented with the URS. This guide wire is there in the ureter, and between these two guide wires, the ureteroscope will be yes, that's how the ureteroscope is going inside the ureter. And in short while, we'll be able to see the stone as well. Once the stone is visible, then the fragmentation options are either with the pneumatic lithotripters or with the lasers. So nowadays, the holmium laser is the most common, and the faster laser is the thulium fiber laser. So with these lasers, the stones, they are fragmented and made into particles. So usually the stones in the pediatric age groups, if they are the calcium oxalate, what we have observed in our practice as well, they are soft. So the dust the dust becomes very quickly, and the intraoperative time is usually lesser than as we expect in the adult patients. But here we are a little more careful after the complete fragmentation. If there is any big stone, we basket that and remove that stone in toto, so that only the dust particles are left. There is no hard fragment inside the PCS. Once the stone is removed, then always we put DJ stent after the surgical procedure. In the PCNL also.
Yeah. Sir, we have lost your voice again.
So as I summarize the treatment options, what we in hand is the shockwave lithotripsy, ureteroscopy, and the PCNL. These are the most common treatment options. The other options, whenever there is additional congenital anomaly, then we have robotic or laparoscopy. So whenever the pyeloplasty is required, then with the same pyeloplasty, we remove the stone, do the pyelolithotomy, and do the reconstruction. So the robotics is also quite safe in the pediatric age group.
Okay, sir. So
the good point is this success. Yes, the stone expulsion. That is, in fact, the kids, they have a ureter which is easily dilatable. So the ureteroscopy, putting the DJ stent, the small fragments, they come automatically. In lithotripsy, usually up to the 10 mm stone, we don't put the DJ stent pre-procedure. So if there is any fragment which is obstructed, then only we put DJ stent. Otherwise, lithotripsy can be done without stenting.
Okay, thank you, sir. After we have learned the management, Dr. Vinay, can we have a brief word of advice about prevention of stones? And then we will take up questions from the listeners.
That's the most difficult part. It is easier if you know what is the cause of stones. And, in 50-60% children, despite doing all the tests that may include the genetic mutation studies as well, we do not know what's the cause, and the stones keep on reoccurring. So I think the basic will come back to the basic things. That is the lifestyle thing, taking less of salt, not taking junk food, the food containing a lot of oxalates. Although we don't put much restrictions on the children, just encourage them to take fresh fruits and vegetables and avoid chocolates and fried chips and, these donuts and all, which have lots of oxalate in that. So and low sodium diet is really helpful. We all Indians have a habit of putting salt on everything. We dahi khate hain ya salad lete hain ya fruits lete hain to uske upar namak dal lete hain. That's really usually not a good habit. And of course, we have to make sure that they have got a good urine output, and environment like in weather like Delhi, it really depends upon, which part of the year you are in. So your water intake will sort of has to get varied. And you may realize that the stones tends to be more in Delhi during this hot, humid weather, because we are sweating a lot and there is a less of water available to the kidney for making this excretion of the solutes. This is some degree of some numbers which are given, and which gives you an indication how much a child should be passing urine in a day. So urine output is more important than the water intake as such. A normal calcium intake is advised, because if you're taking a normal calcium, usually kya hota hai ki if you have got a calcium oxalate or a calcium phosphate stones, they think if by taking too much of taking calcium, that will be doing harm. In fact, a normal calcium intake decreases the oxalate absorption. So that has to be told to the parents. So simple restriction of the junk food and adequate fluid intake is the cornerstone of preventing the recurrence of the stones.
And another frequently asked question is whether hard water has some bearing on the kidney stone incidence. Dr. Rana, what would you say about that?
So actually, what is more important is the water intake and the urine output. The hardness has no significance, and the urine output, what we usually tell patients is should be more than 2 liters per day for the adult, and the urine color is the most important indicator. If it is just like water, that means the properly hydrated body. So in summers, they should increase water intake so as to make the water colored urine. That is the most important thing I think.
So, and last part of the prevention, Dr. Vinay, what dietary changes need to be exercised? You said about calcium and sodium. So calcium oxalate stones we know are common, but do we put all the patients on oxalate restricted diet?
Yeah, it is very easily said than done in children, particularly in adolescent. I think we used to, main emphasis should be on the fluid intake, and then sensible dietary restriction, I would say. If you will say, ye khao, ye nahi khao, ye karo, ye nahi karo, that doesn't happen. So basic thing is junk food should be avoided, or, you give them once a month or something like that. And the things like chocolate should be avoided, adequate intake of calcium. And I think the most important is low sodium intake. And low sodium intake does not mean a different diet, but no added salt is usually good enough. So, to eat too much of chips which have got salt or namkeen, that is not good for children, those who have those who are forming the stones. The fresh fruits and the vegetables have high content of potassium as well as citrate. They are inhibitors of stones, so that has to be encouraged. And oxalates, as I said, mostly in children, which they consume more are the nuts and the chocolates. And some parents are very fond of giving vitamin C supplements, which really is harmful in these children. Vitamin D in the normal doses can be continued, not in the higher doses. Not try to give them a lump sum of 60,000 units like that in a small things have to be continued, because we have to keep in mind the child's growth and the calcium phosphorus content of the bones as well. So simple dietary habits, don't make it too much complicated, because usko implement karna bhi mushkil hota hai bachon ke liye. So fluid, sodium, I would say, and sensible normal diet is the dietary consideration.
So after this elaborate discussion, to summarize, incidence of pediatric kidney stones is rising, and we have to carefully select the patient for evaluation. They need, after acute management, it is very important to do medical evaluation and institute preventive therapy. So without further delay, thank you everyone for patient listening, and we can now take up questions.
Thank you, everyone. Dr. Neeru Jain has asked significance of calcium oxalate crystals in urine routine exam.
So,
Vinay sir?
yeah.
Vinay sir would
So
like
the
to answer.
calcium oxalate stones can be a normal constituents of urine. Its presence or its absence does not signify much. So, but if you have got a asymptomatic child on a routine examination, you see calcium oxalate stone, I think maybe this child is not drinking enough water or the urine is relatively acidic. So just encourage the normal sensible diet and the increased fluid intake, but don't do any investigation further.
Thank you, sir. I request all the all who are present here to post your questions, or if anyone wants to ask, just raise their hands and may ask the question to the experts here. I think for general pediatrician, with kidney stones, if the child comes with a pain pain or painful micturition and hematuria, the easiest thing to do is to refer to a nephrologist or a urologist. Rather than, it's really troublesome to manage such a case. As Vinay sir had rightly pointed out in at the starting of the session, that pain management is the most important thing. We need to comfort the child, and subsequently the managements can be, or evaluation can be done. Yeah, I think we can wind up, Dr. Swati.
Yeah, we can wind up if there are no more.
Yeah, I would like to thank Dr. Swati for such a good to take over topic on medical aspects and lot of surgical aspects and underlying genetic aspect which is there with almost all diseases. I think there's one question Dr.
Yeah.
Geeta has asked: which alpha blockers can be used for expulsion therapy?
Yeah, there are several of them. As pediatricians, we are just comfortable with one, and that is Hyprin. That is the name which comes to our mind. It is a very old drug, but just try, if you want to give it, be careful. It can cause hypotension. So you give it during just before sleep. Don't give it during daytime or when the child is going to run around. So dizziness can happen, but that's pretty good, and it certainly can be used 0.2 to 0.4
So
milligram.
how long maximum we can use this?
Oh no, it really doesn't matter. I think till you have made sure the stone has come out. It doesn't matter. It's got practically no side effects apart from that it causes hypotension. As you know, for older people, this is a drug for prostate which is being used for months and years, and I think they take it for 15, 20 years. It has got no practical other side.
Yeah, prevention is something which needs to be focused at as we pediatricians can do in our day-to-day practice, is to tighten the dietary management, or rather than tightening, trying to reinforce the fact to have a good dietary balance, and especially try to increase the fluid intake in children, which is a really difficult task. Any age group for alpha blocker?
No, no. I will not give to a very small child, because the blood pressure issues and the child will not be able to complain. It is usually used in adolescent, as you say, but it can be used in any age group.
Yeah.
I will not worry about that.
Any role to repeat ultrasound to see? Dr. Rana, if you are there.
Yes. So basically, the alpha blockers, they are safe, but we usually avoid in the infants. In adolescent years, they can be used for 2 to 3 weeks. And if the stones in the ureter and kidney, which are big, not getting the expelled within the period of 4 weeks, then we usually switch over the medical from the medical to the surgical treatment. So in this small these kind of stones, actually lithotripsy is very effective. And for the kids more than 10 years, it can be done just in OPD basis without any analgesia or the anesthesia. But in infants, yes, it is done under IV sedation or in the GA.
So repeat
So,
ultrasound whether it's indicated to confirm whether stone has passed or not.
100%.
Yes, I will do it.
Always do.
I will do it.
Stones are never
will.
silent. Stones are never silent. They are metabolic. They keep on. So 100% we after one.
Yeah, so it's very much required to evaluate the child and to confirm whether stone is passed or not by doing ultrasound.
And if the child has clinically improved, we can do it at an interval after at least 4 to 6 weeks to document that all the changes and hydronephrosis, etc., has reversed. Dr.
So how
Gopal,
safe is how safe is lithotripsy, Dr. Rana?
Yes, lithotripsy is there for last almost 40 years.
Sir, your voice is breaking out.
If there is any coagulation effect or if there is active UTI, we don't do lithotripsy. Once after the infection is controlled or the blood parameters are normal range, then only we do lithotripsy. So it is quite safe. The rare complications are like the hematoma formation. Otherwise, there is no big complication.
Thank you, sir. Okay, I think we are well over the time. I mean, we just over the time right now, and I would again for leading this interesting discussion in the best way possible. Dr. Vinay for taking his time out, and it's your experience is always a blessing for us, sir. We keep learning with every word you say. So thank you so much, sir. Hoping to have more conversations with you regarding nephrology, pediatric nephrology in future. Dr. Rana, thank you so much for sharing your surgical expertise in the field of pediatric renal stones. And Dr. Ranjana, I think she's there. Yeah, Dr. Ranjana for sharing her views on the genetic aspect. And as we all know, most of the diseases right now we are getting a genetic aspect in most of the diseases which we are coming across right now, and this is not something which is surprising. And Dr. Ranjana, you have nicely put all the things across to us with respect to the genetic aspect of renal stones. Thank you so much for all the participants for taking time out and attending this session, and we will be please visit pediatricpractice.com, and all the updates will be provided there, and the recording of this session also will be posted in due time in pediatricpractice.com, and the next session will be informed to you in 2 to 3 weeks time, and we hope to have more further academic sessions in future. Thank you so much.
Thank you.
Thank you all. Thank you.
Thank you, Dr. Satya.